Our second presenter is Dr. Muhammad Umar Khan. Dr. Muhammad Umar Khan is consultant in nuclear medicine and hybrid imaging at the Department of Nuclear Medicine, Al Jahra Hospital, Ministry of Health, Kuwait. He has received the ARCCNM and INCTR awards for his research papers. He is member of Nuclear Medicine Postgraduate Training Committee, site co-coordinator, supervisor for the Kuwaiti Board Nuclear Medicine Residency Program. His areas of interest are molecular imaging in nuclear oncology and hybrid imaging PET-CT and PET-MRI. Dr. Umar has contributed various publications and book chapters in peer-reviewed index journals. Dr. Umar, kindly come and start with PET-MR imaging, a paradigm shift.
Assalamu alaikum, ladies and gentlemen. First of all, thank you very much, the organizing committee, for inviting me here. It's always a pleasure to come and share our knowledge, and it also gives a chance to meet a lot of friends and our colleagues whenever we're back in Pakistan. When the scientific committee gave me this topic of PET-MR imaging, a paradigm shift, I thought that something was missing here. And I did not tell them what I'm going to change about the topic, but I thought that the only thing to add here is primarily an interrogation mark, because it's a question whether it's a paradigm shift or not. And by the end of my presentation, you would have made up your mind whether it's an actual paradigm shift that we are talking about. Just for the overview of my talk, I will give you a global forecast of the growth of PET-CT and PET-MR. As any modality, it has its advantages and also its limitations. I will also take you through our experience of PET-MR services in Kuwait, which are the first in the GCC, and I'll show you evidence-based case log from my hospital. In the end, we'll have a slide discussing the prospects and the challenges that we face with this new technology. As far as the growth of PET-CT and PET-MR is concerned, the compound annual growth rate in diagnostic imaging market is like $34.6 billion US, and PET has its share with about 3.5 billion by 2028. The only thing which is a little concerning here is if you see most of the growth would be the blues and the red, which is North America and Europe. And actually it's shrinking for Asia and Pacific. In the US market, the projection is that by 2030, it's going to grow again, and there's a lot of money going into it. But if you see here, the light blue bars are sustainingly increasing. This is the PET-MR, but there are no way increasing or overlapping or taking over the dark purple ones, which are the PET-CT market. This is the PET-MR map, which is from the European Society of Hybrid Imaging. They did not update it as yet, but this is the version which is currently available from 2022. The yellow ones are the cities where they have at least one PET-MR scanner. The orange ones are where they have two PET-MR scanners, and the red ones are where you have three PET-MR scanners. London and Paris is where you have three at the moment. Just to update you, we have started our PET-MR services in one hospital. There's another camera which is already commissioned and will be starting in 2 months' time. And the third one is scheduled to start by the end of 2025. So Kuwait will be the one in red as well. The advantages of PET-MR are the advantages of both PET and MR separately combined together when they are acquired in a simultaneous acquisition environment. You have precise localization of the abnormal activity, and the lesions are nicely delineated, and the mismatch thing does not affect to an extent as we have in PET-CT, because here these acquisition is simultaneous. You can do the whole body imaging and also do local imaging on the organ of interest or the primary tumor. There's definitely decrease in the radiation dose because MR is not contributing. There's no ionizing radiation. But the most important point is that there's better soft tissue delineation and characterization of the abnormalities. I'll show you these when I show you the case log from my hospital. But this is something which we need to remember. Although there is only a marginal difference in tumor detection as far as PET-MR is concerned, and both are equally good, look at the radiation that is actually decreased when you do a PET-MR study compared to a PET-CT study. It's about 4 times less. And those patients who need repeated PET-CTs, for example, for treatment response evaluation, especially those on immune checkpoint inhibitors for various tumors, and you have to image them every 3 months or 4 months, this would definitely make a difference. But every new technology, or for that matter, any technology, has its limitations. The acquisition time is still long, although there are ultra-fast sequences for MR that have been marketed. The ones that we use are the vendor provided, and they take about 20 to 25 minutes for the whole body study to complete. Having said that, if you see here, this is how the patient would be with the head and neck coil, the upper abdominal array, the lower abdominal array. This takes about 10 to 15 minutes for the technologist to put the patient on. In experienced hands, may take a bit longer for others. So if you put that thing in, so the whole process would be around 45 minutes. The cost, that's a big question. It's still an expensive machine. About 10 years ago, in 2013, I went to attend the Arab Health Conference. The exhibition is a really big one, and they marketed the PET-MR, one of the vendors. And they said that probably in the few years' time, the price will go down because there would be more demand for it. Before coming here, at that time, the price was $5 to $7 million. Before coming here, I checked the price because that would be a question probably everyone would like to ask, like how much it costs and has the price gone down? Just to give you a comparison, a state-of-the-art PET-CT scanner would be $1.5 to $2 million. So it was like 3 or 4 times the price of that one 10 years ago. I checked again. I actually contacted one of the vendors, the one which we have, and the price is still not down. The price for a state-of-the-art time-of-flight, if you want to buy now, is $5 million US, which is again about 2 to 3 times the price of the PET-CT scanner. Moreover, there is a high maintenance cost as well, and there's a lot of things that are involved. There are still problems with the attenuation correction regarding the lungs and the bones. People have come up with algorithms to help with this, assist this, especially in this era of AI. These are AI-generated algorithms, but the problem still exists. It's not like that we are completely over with it. It's a problem for claustrophobic patients, those who are afraid of going in a tunnel. Just imagine if they have to be in this configuration and then again going into a tunnel. So practically, it's not for patients who are claustrophobic. And there are sedation issues. If you want to sedate the patient and put them in an MR machine, please remember the MR safety comes first. So you have to have the compatible MR equipment for anesthesia or sedation if you want to do these patients under anesthesia. So we started our service last year in March 2023. We have a GE Cigna PET-MR time-of-flight 3 Tesla system. When everyone refers to a whole body PET-MR, it's actually vertex to thighs that we do, but you can do whole body as well. Currently, the nuclear medicine and radiology technologists are both involved in image acquisition for these patients, and both of them are trained for MR safety. And the MR safety is a very vigilant process that goes on, and it's, you cannot go without that if you want to run a service. Currently, no MR contrast is being administered at present. The exception is cardiac PET-MR, where we have given contrast in 2 patients. The MR sequences that we acquire are for attenuation correction, the T1, water, fat, in-phase, out-phase. The T1 lava, we have a 3D configuration with T2 Fiesta as well, where you can see the images in cross-sectional, just like you see in the CT part of it. You can see on coronals, but primarily it's the axials on which you report. We do the diffusion-weighted images with a B-value of 50 and 800, and also generate the attenuation ADC images. At present, because this would be again a question, so I've put it here, a nuclear medicine physician who is trained in PET-MR is reporting the study, with the radiologist giving their input as to any relevant MR finding which is clinically relevant. So the nuclear medicine physicians are trained to report on the abnormal and normal distribution of the radiopharmaceutical, correlating with the MR sequences for further describing the location and if there's any signal abnormality. And it's primarily as a template that you use in CT. You can do the same, get yourself trained in the MR part of it. And because PET-MR is not MR, these sequences are not actually the diagnostic MR sequences when you're acquiring the whole body. Otherwise, it would take about 60 minutes of your time. These sequences are called single shot fast spin echoes, the SSFSEs. In the initial phase, we had to standardize the protocol. So there was a learning curve where we did about 42 PET-MR procedures after PET-CTs, and without any extra dosage to the patient and with their consent. This helped us in learning how abnormalities look different on PET-MR when compared to PET-CT. So whichever center has started a PET-MR service prior, they always try to come up with these learning curves where you would like to know how your imaging acquisition looks, whether it's optimal or not, and you need to standardize the protocols for your running of your service in an optimal manner. So till last month, the data I collected, we have done over 100 PET-MR studies, and these include the whole body PET-MRs in for oncology. We've done brain and cardiac as well. The case mix is like almost half of them are from oncology, followed by neurology, guiding biopsies, and for infection and inflammation imaging. The oncology primarily is with lymphomas, breast, GI, gynecological malignancies make about 3/4 of our cases, and these are primarily the ones where there is evolving evidence or good evidence that you can do a PET-MR would be better or equally good as a PET-CT. For neurology, we have done it for dementia imaging, for mild cognitive impairment. We have done as young as 3 years old, and we have done as old as 84 years of age. The tracer primarily that we use is F18 FDG. We have access to gallium-68 DOTA knock. We've done about 5 patients. We've just done 2 PSMA gallium-68. Primarily the reason is that in Kuwait, all prostate patients go to a center which is known as Jabir Al-Ahmed Molecular Imaging Center, and we started using 1418 PSMA to image these patients, and this shift was about 1.5 years ago when there was problems with the availability of the gallium generators. We use the low dose protocol. It's still 0.08 millicuries per kilogram body weight. So the radiation exposure or the radiation dose cumulative that I showed earlier was not with 0.08 millicuries per kilogram per body weight. That's the standard one, which uses sometimes 1 millicuries or even more. So in practice, you would be giving even less dose than what I've shown you. So good is not good when better is expected. Like there has to be a comparison, like did we do enough in the last year or so? So this slide, which this is from my friend Sergios from University of Tübingen. I did my PET MR first training at the center in 2012, 2013, and he showed that when they actually started, it took them about 2 years to actually reach about 100 cases, and the learning curve was the same, like they were doing more of PET CTs followed by PET MR. So considering this experience, which is, well, this started off in 2011, I think it's comparable, and we have done a good job probably with the shorter learning curve in Kuwait. We'll move on to clinical cases. One thing to remember here is, like for PET-CT, we have evidence-based guidelines, freely available, tested in prospective trials. And what's lacking here, even over the past 10 to 15 years, when PET-MR was promoted, marketed, and thought of as an alternate to PET-CT, still you don't have concrete evidence-based guidelines. There was something which came up last year. It's a consensus recommendation, primarily only in oncology. The problem here is that if you read this paper, in the end, you can do PET-MR for everything for which you can do a PET-CT. They've not been much of a help. In summary, what these guidelines say is, like, if MR is good for one particular oncological scenario, you can add those diagnostic sequences to your whole body PET-MR, and then it is as good as PET-CT or probably better. But this is something we already know. If we do that in real time, it would be more than 60 minutes of imaging, which is practically not possible, what we have seen. Secondly, most of the patients who turn up, and if they do not get into triage or an MDT setting from the very onset, most of these would have done a diagnostic MR, as we see in cases of PET-CT. So there's no need to put them again into that ordeal, depending upon when was the PET-MR done. If it's not in the in the recent past, then definitely you can go for the one-stop shop. One of the evolving evidence, and we've particularly experienced that it's probably good, is in patients with lymphomas. Now, this is from 2014. When all this thing was started, they concluded that you can use PET-MR, and it's equally good and an alternative for staging and follow-up. Now, but this was not in a prospective trial. It was like, I think, only 28 consecutive lymphoma patients that it took. They did it in a prospective trial as well, and this came out 2 years ago, and they validated that, yes, it's good enough. Not only that, it's not only the lymphoma itself, but what's important is if you go through the evidence-based guidelines of PET-CT, which the recent version that came up in 2022, for all pediatric cancers, including lymphomas, PET-MR seems to have done a better job. And the reference that they give is where they think that PET-MR has a good evolving evidence when you talk about cancers in children. And lymphoma is the one where you have now enough evidence. The protocols have been standardized in various centers from US and Europe. We used the first one. And there's a lot of good papers who came up from Stanford as well. But this is something I want you to have a look. This is very recent. You don't need MR contrast. It's understood that the whole body PET-MR for lymphoma, whether it's for staging or follow-up, would be enough. You do not need contrast enhanced MR. We were just discussing this before the start of presentation, like most of the centers around the world do a PET-CT without contrast. And many people are proponent of giving contrast. But in real time, in most of the states, most of the countries, most of the clinical scenarios, we actually do not need to give contrast unnecessarily. 2 to 3 minutes won't be able to make it. This is how the PET-MR looks. It's a 15 years old. You can see extensive disease, almost intermediate signal on T1, high signal on T2, diffusion restriction with a low ADC. And this is the normal pattern of correlative MR that you do with a PET, like usually they are low to intermediate on T1, T2, they're usually high signal, and diffusion restriction, as you see on the DW images, it has to be low on ADC. If they're high on ADC, then that's not diffusion restriction, and they're not relevant. This is a patient who was done as a baseline, post 2 cycles for responding, and end of treatment. You can see over the period of time that this is responding well to treatment, almost a complete metabolic response, also of Hodgkin's lymphoma. We did PET MR for this patient. So again, when we come to this, just imagine, like, for 3 studies, the cumulative dose in PET-CT would be around 60 millisieverts, but probably less than 15 if you've done a PET-MR for these patient. Neurology is very important. It's very popular with the neurologist. They do it for Alzheimer's disease, for dementia imaging. And the sequences that we do are the Bravo and the T2 FLAIR. The soft tissue delineation is immensely wonderful. Like if we do a PET-CT of FDG and the CT that we do, this is really very helpful. This is a normal distribution, although the patient was 45 years old for forgetfulness, headache, and episodic depression. But I'll show you the next one. This is 59 years old with episodic memory dysfunction, and you can see that there is bilateral hypometabolism in the temporoparietal lobes with reduced uptake in the central gyrus, sparing the occipital lobes. And if you see the relevant MR images, there is in the areas of abnormal uptake, there's widening of the sulci, and you see the atrophic changes in the brain. My pointer moves slowly. That's why you need to give me 2 or 3 minutes extra with the permission of the chair. See. Okay. Large vessel vasculitis, we have referral from the rheumatologist. I haven't seen a positive case. We have done 5 or 6, primarily because these patients are usually on steroid treatment, and the sensitivity of PET imaging, whether you're doing a PET-CT or PET-MR, in any case goes down. But the important thing is the coronal T2s are nicely seen here, and for fusion and for evaluation of these vascular things, this sequence is pretty helpful. PET-MR for lungs is not that good in our experience. But when they started off by saying that if you do a contrast wipe sequence, you may pick up more lung nodules on MR, or equally as good as that. But there was conflicting evidence from Korea where they said that there's no add-on advantage of using that sequence. In 2016, they even went on to give this study where they say that majority of the ones which you don't see are benign, which is a little tricky, which means like if you don't see it on PET-MR, or if you miss it for that matter, mostly they would end up benign, which in a clinical scenario usually do not work for the oncologist. This is a patient of triple-negative breast carcinoma. For PET-MR, if it shines, you can report it as suspicious, but MR images do not give you the morphology. You have to do either a low-dose CT with this one, or more recently what we have started off doing, we do a PET-CT followed by the PET-MR in the lungs only, so that we can evaluate tracer-avid or non-tracer-avid lung nodules for the oncology patients. Guiding biopsy, here you can see there is a peritonsillar mass, low on T1, high on T2, again, diffusion restriction, low ADC, and this biopsy came out to be lymphoma. Okay, so let's go to the challenges, the last slide. There are a lot of challenges. You have to convince the referring physician. For that, you need to have training courses. We had one last year with the collaboration of the IAEA. You need to train your residents, nuclear medicine residents, I'm talking about. For PET-MR, we've already included that in the Kuwaiti board's program in nuclear medicine. You have to collaborate for one-stop shops with radiology. There is a lot of potential for research. You can collaborate with universities, and there are a lot of artificial intelligence and deep learning algorithms. That's a complete separate talk for PET-MR, where you have a lot of potentials, and you need to devise a policy on contrast management. If you have it, use it. If you don't have it, you're not missing out much. The current status, as I told you, it's very popular with the neurologist. The oncologists are okay. If you do a PET-CT for them, do a diagnostic MR. If you have the PET-MR, they want you to do the diagnostic MR sequences as a one-stop shop, but also add on CT. Cardiologists, they're still learning cardiac MR, so cardiac PET-MR is still beyond their... So thank you very much, everyone. It is not possible without the team. This is our team at Jahra Hospital. And I feel really proud being a nuclear medicine physician from Pakistan working in Kuwait to report the first PET-MR case last year when we started. It's indeed an honor and privilege both for me and Pakistan. Thank you very much.